Good morning, everyone. Thank you for being here. Today, we're confronting aortic dissection, one of the most urgent vascular emergencies. A tear in the aortic intima creates a false lumen that can fatally compromise blood flow in minutes. Dissections come in two flavors. Type A, tearing through the ascending aorta, demands immediate surgery. Type B, down the descending aorta, often begins with medical control. Patients describe excruciating, ripping chest or back pain that may radiate along the spine. Hypertension is common, though pressure can plummet if rupture occurs. Look for asymmetric pulses or new murmurs of aortic regurgitation, and never ignore sudden neurologic deficits. That dissection can occlude carotids or branch vessels. Our first diagnosis step is clinical suspicion. In any patient with tearing pain at onset, especially those with hypertension, Marfan features or stimulant use, measure blood pressure in both arms. A difference over 20 mmHg or weak radial or femoral pulses are red flags. Listen for muffled or added heart sounds if tamponade has set in. Next, get imaging. CT angiography is the workhorse, rapid, detailed, and widely available. If the patient cannot go to CT, a transesophageal echo at the bedside can visualize the proximal tear and complications like effusion or regurgitation. Transthoracic echo has its limits but can detect tamponade or proximal involvement. A chest X-ray, though not definitive, often shows a widened mediastinum. On ECG, you might see LVH, or in proximal dissections, signs mimicking an inferior MI. Caution, treating such a case with fibrinolytics would be disastrous. Labs like D-dimer can support but never rule out a dissection if your suspicion is high. Use the ADDRS risk score, high-risk conditions, pain features, and exam findings. Any moderate high-risk patient deserves immediate imaging and management. Low risk with negative D-dimer may be observed, but dissection kills quickly if missed. Treatment begins at once. Reduce shear stress on that fragile aorta. Give an IV beta blocker, esmolol or labetalol, to lower heart rate below 60 and blunt the force of each beat. Then, if pressure remains high, add a vasodilator like nitroprusside, but only after rate control to avoid reflex tachycardia. Morphine eases pain and calms sympathetic storms. Monitor blood pressure in both arms, consider an arterial line, and keep eyes glued to the monitor. For type A dissections, call cardiothoracic surgery immediately. This patient needs the OR, not the cath lab. In type B, we often manage medically in the ICU, watching for complications. If end organ malperfusion or rupture develops, vascular or cardiothoracic teams will intervene with stent grafts or open repair. Remember, never give thrombolytics if you suspect dissection. If tamponade from rupture complicates things, pericardiocentesis is a controversial bridge, but surgical repair is the real answer. And in acute aortic regurgitation, surgery again is life-saving. In the meantime, head-up posture and tight blood pressure control help reduce regurgitant volume. Post-procedure, these patients belong in the ICU. Continuous hemodynamics, rhythm, and urine output monitoring are non-negotiable. Sedation and analgesia keep them calm and prevent surges in pressure. In disposition, type A patients go directly from the ED to surgery and then to the ICU for recovery, remaining on lifelong V-blockers. Type B cases are managed in the ICU, transition to the ward once stable, and are discharged on oral antihypertensives. Both require periodic CT, MRI surveillance and should avoid heavy lifting, maintain strict blood pressure control, and seek immediate care for any recurrence of tearing pain. Aortic dissection is a race against time. Rapid recognition, targeted medical therapy, and timely surgery save lives. Thank you for your attention. Let's discuss your experiences and any questions you have.